I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
AKA PharmD and I'm bringing you another episode of the Pharm So Hard podcast. I have probably the best show that every single one of you are going to love. This is going to be the most downloaded episode, the most requested topic that I've been getting across the board. We're talking about Vancomycin, Vancomycin and Zosyn in its association with acute kidney injury. But again, I'm not going to sit here and talk about something I have an expert on, and this is going to be just really cool to be able to go straight from the bedside to talking about things from a literature standpoint. I have Todd Miano, and he has been super gracious to bless us with his time. But let me give you a little bit of background before we jump into the show again, because when we have a huge expert like this, I really want to tell you guys more about him. So Dr. Miano is a critical care pharmacist at the Hospital of University of Pennsylvania and an assistant professor of epidemiology at Perelman School of Medicine. He is also a fellow of the American College of Critical Care Medicine, international editor of the British Journal of Clinical Pharmacology, and associate editor of the BMC Pharmacology and Toxicology. Dr. Miano's research increase leverage in economic health record data to study drug safety and comparison efficacy in critically ill populations. And his work seems to understand drug effect heterogeneity and quantify the impacts of variable responses of outcomes. So again, I mentioned a few things there, but can you give us a little bit more about your hometown, residency, and fellowship? And again, thank you for coming onto the show.
Sure, and thank you for having me. Excited for the opportunity to talk about our work and this topic. I am originally from a very small town, Dungannon, Virginia, in rural southwestern Virginia, population of about 300 individuals. We didn't even have a stoplight in the town. So I went to residency at pharmacy school at Virginia Commonwealth University in Richmond. Did residency at Wake Forest Baptist Medical Center, both my PGY1 and then PGY2 in critical care. And then I practiced as a critical care pharmacy specialist at the Hospital of the University of Pennsylvania in Philadelphia, and in the surgical intensive care unit, and did that for about 6 or 7 years before doing a research fellowship and getting a master's in clinical epidemiology from the University of Pennsylvania, and then went on to do complete a doctoral degree in epidemiology, and just started as an assistant professor here, still at Penn. Yeah, so I think that covers it.
Yeah, you pretty much hit all the things, and I'm gonna go ahead and jump right into this. So I want to talk about, again, we've all heard about vancomycin and piperacillin tazobactam. I'm going to call it Zosyn from now on. I know people hate doing it, but I like to call it Vancozyn. It caused an AKI in the past. What is the proposed mechanism of this nephrotoxicity?
So that's a great question, and I think that is the crux of the entire story, and the motivation for our paper. There has never really been a mechanism, or perhaps a really plausible mechanism postulated. So obviously, vancomycin is nephrotoxic, can cause acute tubular necrosis through oxidative stress and cast formation. And we learn more every year about the nephrotoxicity of vancomycin. So it's clearly nephrotoxic. Piperacillin tazobactam, Zosyn, on the other hand, historically has never really been. We had clinicians wouldn't think of Zosyn as a nephrotoxic. Outside of acute interstitial nephritis, there are certainly case reports of that adverse effect, much like many other beta-lactams. And the background rate of interstitial nephritis with Pip/Tazo is probably not, meaningfully different from other beta-lactams. And so some folks have postulated that perhaps that, there's this interaction between vancomycin nephrotoxicity and interstitial nephritis from piperacillin and tazobactam, but it's, that was never really that compelling because interstitial nephritis is uncommon enough that it would be plausible that it would explain the strong associations seen in the literature. So yeah, I wish I had a better answer for you, but again, that's part, an important part of the story. So as of today, in terms of a plausible mechanism of true toxicity, that's an open question.
And that's where I really want to get to, because I think sometimes we learn in pharmacy school and, sometimes you get in training and you hear these same things repeated over and over that we never really go back to check and see. So when we do, and we don't actually find something, or the incidence of these things occurring are so low, we have to ask ourselves like, hey, is this really something that we should be doing? And we spoke a little bit earlier of how I've made our sepsis guideline. I've done a few things. And one of the big motivations to avoid the combination was AKI. But again, as we commonly do now, is go back and look at these things and study them. We come up empty handed for the most part.
Yeah. And you're not alone. So there are many institutions across the country and perhaps across the world that have moved away from the combination of vanc and piptazo. Perhaps jumping ahead a little bit, but that those changes were based on the literature that has accrued around this question over the past almost a decade now. So at this point, there have been at least 50, but 50 to 75 observational studies that have linked the combination of vanc piptazo with an increased risk of acute kidney injury. Some of those studies have compared vanc monotherapy versus combination therapy with vanc piptazo. Many other studies have compared vancomycin with piptazo versus another beta-lactam, which is a better design because it probably does a better job of reducing confounding by indication. Using many different comparators in many different populations: critically ill patients, non-critically ill patients, pediatrics, transplants, burns, trauma, you name it. It has been studied, and what's remarkable is that the signal that signal is consistent. So I think I believe that there is an association between I think it's a true association between and so this is the key point between creatinine defined acute kidney injury and the combination vancomycin and piptazo. And so that kind of leads into kind of the hypothesis that we tested. So, as many of the listeners probably know, creatinine is the most common biomarker that we use to monitor kidney function, but is by far is far from being a perfect biomarker. So obviously, steady state concentrations are affected by other factors beyond changes in kidney function, right? So changes in muscle mass, changes in diet, changes in liver function, all affect the input of creatine, which is metabolized to creatinine. So that complicates the interpretation of creatinine. And as pharmacists, right, we're constantly every day thinking through those issues when we estimate kidney function. But it's also true that changes in creatinine, which we use to diagnose acute kidney injury, do not always represent changes in kidney function. And so that's one of the key limitations when using creatinine to diagnose acute kidney injury. So the KDIGO consensus criteria use either at least a 50% change from baseline in creatinine to represent acute kidney injury, or a change of 0.3 milligrams per deciliter within 48 hours. So even rapid small changes can be acute kidney injury. And the assumption is that change in creatinine is the result of change in kidney function that is the result of some underlying injury. And so it turns out that's not always the case. So especially critically ill patients, right? So we often we resuscitate patients with many liters of normal saline, lactate, other resuscitation fluids, which have a well-described dilution effect on creatinine and other markers. And importantly, a number of drugs have been shown to impact creatinine concentrations based on the fact that while creatinine is filtered in the glomerulus of the kidney, it's also secreted from the blood into the lumen of the tubules through the organic anion transporters. The OAT1, OAT3 are thought to be some of the key transporters that mediate that. So on average, about 15% of creatinine clearance does not represent filtration. It represents secretion. And for that reason, creatinine clearance is not the same as glomerular filtration rate, right? So creatinine clearance does not equal GFR, and the reason for that is secretion. And on average, the rule of thumb that we use is about 15%, but that varies, particularly in the setting of reduced kidney function. The proportion of clearance due to secretion generally goes up. So in patients with chronic kidney disease and end-stage renal disease, secretion may account for 40% as high as 60% of creatinine clearance. If drugs are given that affect tubular secretion, the magnitude of change in concentration that you would expect would be magnified in patients who have, a greater percentage of their clearance due to secretion. So creatinine is an imperfect marker of kidney function and kidney injury. And so that notion is what underlined the hypothesis that we tested in this study, and that's been, discussed in the literature. The notion that the combination of vancomycin and piptazo does lead to changes in creatinine, that's a true association, but that those changes are due to effects on tubular handling of creatinine, inhibition of tubular secretion. And so that's specifically the mechanism that we set out to test in our study.
Perfect. So before we get into the actual study, because I'm ready for that as well. So we've mentioned quite a bit how creatinine in itself is an imperfect marker. What are some of the other markers? I think this has been something that I saw during residency. I think many institutions are starting to see the infancy of the other markers to test for kidney injury. What are some of those other markers that we can be using?
Yeah, so the field of AKI biomarker research has really evolved and grown substantially over the past, almost 2 decades now. And so beyond creatinine, there are a number of, ways to monitor both kidney function and kidney injury. So obviously there's urine output, which is also part of the current consensus criteria for defining acute kidney injury. Beyond creatinine and urine output, there are other markers that we can measure both in the blood and in the urine. So at this point, there are dozens of biomarkers that have been studied. Some of the most commonly studied, perhaps most well known, include cystatin C. So cystatin C is an alternative marker of kidney function. So cystatin C is 100% cleared through glomerular filtration, and importantly, does not undergo tubular secretion. So cystatin C has been validated as a marker of kidney function. In 2012, the CKD-EPI group published GFR equations that were based either only on cystatin C or both on the combination of cystatin C and creatinine. And there's a decent sized literature that has described the role of cystatin C in critically ill patients, both for estimation of kidney function and diagnosis of acute kidney injury. So cystatin C is a functional marker. So like creatinine, is not directly reflective of kidney injury. And so sometimes there are changes in kidney function that don't necessarily represent kidney injury, or changes in filtration. So for example, when we give a RAS inhibitor, like an ACE inhibitor or an ARB, that causes vasodilation of the efferent arterioles, which reduces the intraglomerular pressure that drives filtration. So, there's an acute change in kidney function, but that's not really associated with actual damage to the kidneys, right? It's not changing blood flow, causing ischemia or any actual injury. So cystatin C is, advantageous in that it doesn't, it's not subject to secretion, but again, it's not a perfect biomarker. And particularly relevant in critically ill patients, cystatin C can also change in response to factors other than kidney function. So cystatin C is affected by inflammation and the administration of corticosteroids. So both inflammation and corticosteroids can cause acute increases in cystatin C. Other factors linked with changes in cystatin C have been thyroid function, malignancy, obesity. So it has advantages relative to cystatin C, relative to creatinine, but it's also not perfect. Now, another important thing to mention about cystatin C is it has a shorter half-life relative to creatinine. So an important limitation is that, on average, if there's an acute change in GFR, if I cut out one of my kidneys today, on average, it might take, 12 to 48 hours for a new steady state creatinine concentration to be achieved. So there's this built-in delay and so cystatin C has a shorter half-life. And so on average, you would expect to see changes in cystatin C sooner than you would changes in creatinine. So cystatin C is an important alternative biomarker that is being used more commonly, both for estimation of kidney function and monitoring of kidney injury. There's a whole host of other markers that typically are measured in the urine that are directly reflective either of kidney stress or kidney injury. So actual damage or stress to the tubules in the kidney. The cell cycle arrest markers are markers of kidney stress that have been well validated and are actually FDA approved for monitoring, and particularly in the setting of trying to anticipate risk of future acute kidney injury. NGAL, KIM1 are other markers that are secreted into the urine in response to cellular damage in the proximal tubules. And so many of these markers have been fairly extensively studied and have been shown to, better associate with risk of, downstream outcomes relative to changes in creatinine. And there are studies that have shown, discordance between what these alternative markers are telling you and what changes in creatinine tell you. So, there are patients who have changes in creatinine, but no change in the biomarker, and those patients do okay. Whereas you have other patients who have changes in the damage biomarker and no change in creatinine, and those patients do worse on average. So, the future for monitoring kidney function and the effects of nephrotoxins, we're still not there yet. Many of these biomarkers are still, not quite ready for prime time. And a lot of them are, not widely available, still very expensive relative to creatinine. So, rolling them out in large scale, there's still a lot that we need to work out. But, the future is monitoring kidney function with a panel of markers, and in select patients using some of these alternative damage biomarkers to suss out exactly what's going on with the kidney.
Perfect. All right, so let's transition to this paper. Everyone's been talking about it. It's been blowing up on Twitter. Let's just go ahead and talk about, again, we discussed it a little bit before, but what was the primary objective or aim of this paper?
Yeah, so we came into this paper the hypothesis that the changes in creatinine that were associated with the combination of vancomycin did not reflect actual changes in kidney function or kidney injury. And so, how could we test that? Well, the most direct way to test that in humans would be to measure an alternative marker, either of kidney function or of kidney injury directly. And so I had the good fortune, am surrounded by, brilliant researchers, and among them, Michael Shishati, who's a pulmonary critical care physician at the University of Pennsylvania, and Nuala Meyer. They're two of my research mentors. Nuala leads a prospective cohort study of sepsis called the Molecular Epidemiology of Sepsis in the ICU, or the MESSI study. It's a prospective study that's been enrolling patients, medical ICU patients with sepsis since 2008. And at this point, there are over 4,000 patients that have been enrolled. And so the aims of this underlying prospective cohort study are to, as the name suggests, understand the molecular epidemiology, the molecular mechanisms of acute organ failure in patients with sepsis. And so this study, all patients that are enrolled have blood samples taken at baseline, which is the time of admission to the intensive care unit, and then roughly 48 hours. So at baseline and at 48 hours. So all these patients had plasma samples available where we could measure an alternative marker, and so the most validated marker for kidney function outside of creatinine in the blood is cystatin C, and so that's how kind of we settle on cystatin C, knowing that it's not subject to tubular secretion, and so it would allow us. So in this population, in the MESSI population, we identified patients who received either vancomycin and piptazo or vancomycin and cefepime as the comparator. And we contrasted changes in creatinine with changes in cystatin C. And our hypothesis was that there would be a discordance in those two biomarkers. We expected to see vancomycin associated with a change in creatinine, but not associated with changes in cystatin C.
Perfect. So again, we've kind of talked about a little bit before in that mention there, but can we kind of describe kind of this cohort outside of when enrollment and talk about the outcomes? It's basically all your methodology. Kind of go through that a little bit.
Yeah. So so in this MESSI cohort, which is patients with sepsis, a fairly high baseline severity of illness. So, the mortality in the overall cohort at 90 days is about 50%. So high mortality risk population. And so we identified patients who received, either of the comparator combinations, vanc with either cefepime or piptazo, who had drugs initiated within 48 hours of ICU admission, and who received the combination for at least 48 hours, so that we could, measure change of the biomarkers at day 2. And so our primary outcomes were changes in biomarkers at day 2. So the change from baseline to day 2. And so because the timing of antibiotic initiation and the timing of the overlap between vanco and the beta-lactams varied around ICU admission, right? So some patients would have the antibiotics started a little before ICU admission, some a little after. Some would have vancomycin initiated first. Others would have the beta-lactam initiated first. So there wasn't, for all those reasons, there wasn't a perfect alignment of antibiotic initiation with the timing of the blood draws. Okay. And so we had to, so a priori we designed, we specified windows of time in which the blood draws would be eligible for our analysis. So the blood draws the baseline blood draw had to be within the 24-hour window prior to antibiotic initiation. And then the follow-up blood draw had to align with the 48-hour window after from hour 48 to hour 72 after antibiotic initiation. So that the changes that we were quantifying could be plausibly related to the effects of antibiotic administration. So for that reason, not all patients that we were able to include had cystatin C measurements available. So we included 739 patients. Only 192 had, the timing of their blood draws in proper alignment so that we could include them in the cystatin C analysis. So an important limitation of our study is, although our overall sample size is fairly large, the sub-cohort with cystatin C is, much smaller. To try to mitigate or supplement those analyses because of that limitation, we also looked at changes in BUN as an additional secondary marker of kidney function that does not undergo tubular secretion. So BUN is far from a perfect biomarker like creatinine, and it's also affected by many other factors. So its specificity for changes in kidney function, is far from perfect. But we viewed that as, just an additional secondary marker, to compare with changes in creatinine, recognizing those limitations. And then we also looked at some patient-centered outcomes that we would really, hard outcomes that we would care about. If the acute kidney injury that is occurring, that is related to Vancozyn, if it's actually true kidney injury, and it's something that we care about, you might expect to be associated with downstream events that we associate with acute kidney injury, including the need for renal replacement therapy and mortality. So, much of the reason why we care about acute kidney injury is that it's associated with these downstream outcomes that, that patients care about. So we also look at those outcomes, and our hypothesis would be, again, a discordance between what we're seeing with creatinine and what we're seeing with those outcomes. We hypothesize that we would see increases in creatinine associated with vancomycin, but no association between vancomycin and changes in either cystatin C or BUN or those downstream outcomes that we care about. So that's kind of an overview of the cohort and the outcomes that we looked at. So it's a critically ill cohort, as I mentioned, so high baseline severity of illness, and it's an observational study. As would be expected, there were differences in the groups that were being compared at baseline in terms of their baseline severity of illness and risk for true acute kidney injury. And in general, the vancomycin group at baseline had a higher severity of illness at baseline, and they had a higher Apache 3 severity of illness score. They had a lower baseline kidney function, and if you looked across many of the baseline covariates that we measured, they tended to trend in the direction of the Zosyn patients being a little sicker. So trying to adjust for those differences in baseline risk was a key part of our analysis. We used inverse probability of treatment weighting, which is a type of propensity score based analysis that basically a propensity score for receipt of vancomycin is estimated, and that propensity score, and then patients are then weighted by the inverse of that propensity score. And what that weighting tends to do is, in the weighted population, removes associations from treatment and baseline risk for the outcome. So essentially, it balances the distribution of the baseline confounders that we included in our analysis. So that was a key part of the analysis, is the weighting to adjust for confounding. A number of the key confounders that we wanted to include were missing in a lot of patients. So, important lab variables in particular, bilirubin and albumin are both, acute phase reactants, markers of baseline severity of illness. Bilirubin is a marker of liver function. Both have been, shown to be strong risk factors or predictive of risk of acute kidney injury. Some vital sign measurements like mean arterial pressure were also missing. And so we wanted to be able to adjust for those factors and account for the missingness. So we used a procedure called multiple imputation, which is a way to basically predict what those missing values would be in a valid way. So we addressed missing data with multiple imputation. So our analysis used the combination of inverse probability weighting and multiple imputation. So all of our final adjusted estimates came from that, multiply imputed weighted analyses. So I think that probably, and I think that covers the key aspects of the methods. Yeah.
And the big thing is now it's like we talked about all these different components. And if you can give like an overview of, I try when we have these kind of conversations, talk about what did this patient look like? You mentioned they're very sick. Again, 50% mortality is solid. These are very sick patients. But overall, if you had to choose like 3 or 4 things to give a good highlight of what this patient looked like, what are some of the things that was your average patient as far as baseline characteristics?
Yeah, I mean, I think the average patient, was admitted to the emergency department with sepsis, transferred, directly to the intensive care unit, high dose pressors, receiving lots of fluid resuscitation, really sick. A MICU population, so a high prevalence of patients with cancer and, cirrhosis and liver dysfunction.
Perfect. All right. So we basically went through most of the background. I think this is the part that everyone wants to hear about. So I'm going to put a quick little pause here before we go into it. All right. Big moment here. Tell us about the results of this study.
Yeah. So what we hypothesized to see is kind of how the results turned out. So when looking at change in biomarkers at day 2, so the change from baseline to day 2, what we saw was that vancomycin was associated with a significant increase in creatinine at day 2 from baseline. And so we looked at that both as a continuous measure. So, percentage change from baseline as a continuous measure. And then also a threshold change. So we looked at the incidence of a 50% increase in all of the biomarkers. And so the piptazo was associated with a roughly 2-fold increase in the frequency of a 50% increase in creatinine from baseline at 48 hours. In contrast, piptazo was not associated with change in cystatin C or change in BUN. In fact, both of those markers trended to be lower in the vancomycin group relative to the cefepime group. And the combination was also not associated with need for renal replacement therapy or mortality. So, across all of our results, what we tended to see was that vancomycin was associated with creatinine-defined outcomes and not any of the other outcomes that we looked at. And so what is driving that pattern of results, right? We didn't directly look at mechanisms, but we can hypothesize that pattern of results is consistent with the hypothesis that we came in with, that the effects of the drug combination represent isolated effects on creatinine, and does not reflect actual, kidney tubular damage.
Perfect. Now, one of the things that we noticed when we're comparing a lot of this with cefepime, again, as we move forward, do you see anything future looking at that? Because again, that association may be more so the actual kidney injury with the cystatin C and BUN looks to be a little higher in the vancomycin group. do we see anything moving forward where we want to see whether that combination may be associated with increased actual events using those things, or what's like the future aims for this topic? Because again, I can see this going many ways.
Yeah. So, we did the best job that we could to try to address this hypothesis. But, this is just a single study and it is far from perfect. And, at the end of the day, we only had cystatin C in 192 patients. So I think the results are important in that I think they really shift the balance of the evidence, more towards equipoise. Okay. I think before our study was published, most folks took this as to be a true thing, right? I mean, many institutions, many clinicians have changed their practice to avoid using the combination. In fact, last year in Clinical Infectious Diseases, there was a study published out of Vanderbilt where they, implemented a stewardship intervention where they drastically reduced the use of Vancozyn relative to vancomycin. It's an important combination. In 2016, in fact, Vancomycin and Zosyn were the two most commonly used antibiotics in hospitals in the United States. So it's very important. Zosyn is a workhorse for a good reason. It's broad spectrum, but in terms of collateral damage and from a stewardship perspective and inducing resistance, it has favorable characteristics. There's some data that suggested it may have a lower risk of C. difficile diarrhea. There are other toxicities with our comparator antibiotics. Cefepime and neurotoxicity, meropenem, and adverse collateral damage in terms of resistance. So I think it's still an important combination that we should have available to us. And so I think our data suggests that the door is far from closed on this question. I think we need more data like ours, looking at this question with biomarkers beyond, with ways to monitor the kidney in addition to creatinine in larger populations. Even in our study, even though we did the best job that we could to try to address confounding, at the end of the day, observational studies, are subject to biases from confounding that can be, difficult to fully, to be confident that we've removed all the confounding that is there. So, eventually randomized studies of this question that are, looking at alternative biomarkers, might be what's needed to, finally end the debate.
Perfect. And this is something that I think most people are going to hear and act like, okay, this is big. This is a big paradigm shift right now. So again, and I understand from when you create this, and most people who are doing great studies, they tell us, hey, there's tons of limitations. This is only observationals, but just as well as I do, people are going to take this and run with it. But before they do that, what do you want clinicians to do with this information at this time? Or would you say, hey, I just want you to do more research. Like, what do you want people to do right now at the bedside with this information?
I try to hold my own work up to the same standard that I would hold others' work. For that reason, I couldn't quite say that I don't think this should be practice changing necessarily. But if you are a clinician or a hospital that continues to use Vancozyn, if you are confronted with a patient who you think needs Vancozyn, for example, if you had a patient with, that had been in the hospital for 2 weeks and had already seen vancomycin for a week, and you think, we should probably switch to Zosyn, you should feel much more comfortable in using that combination. And perhaps, evaluate, and if you have a patient that's being treated with the combination and you're seeing changes in creatinine, perhaps, be a little bit more thoughtful in your evaluation of what's happening with the kidney. Look at other markers, look at the whole clinical picture. And maybe there doesn't need to be a knee jerk. The creatinine's going up. Let's stop the Zosyn and switch to something else. So I think it should be reassuring for folks who have continued to use the combination, and for others who have switched totally away from Vancomycin. I think if you have a patient who you think it would be a good combination, a good treatment for, you should feel more comfortable in doing that.
Perfect. That's phenomenal. And I think my providers are going to love hearing this, because if there's one thing that they do, they Vancozyn everything that moves. I think if anything comes in, if it's CAP, if it's a UTI, I have to I say, okay, I understand what you're trying to do here, but let's put the big guns away. But they're going to really enjoy this for the sick patients. And I think that's the key thing that I got out of this. This is a sick population. This is the one that comes in that you have vasopressin on within an hour or so. You already got norepi running at a pretty good rate. They've getting antibiotics. These are the people who you should be okay with. And I think that using creatinine as a sole marker, I always ask myself, in the next 5 to 10 years, will something change? And it seems to be that this may be something that changes as far as definitions with our guidelines and how we do things in the hospital. Because again, there's, as you mentioned earlier, tons of markers we could use to identify function, but there's also a ton of markers we can use to define injury. So I think that's my big takeaway from all of this, is that it's an entire picture, and we should not try to dumb down things and just use creatinine. But again, this is something that I think really going to help people when they're making guidelines, whether or not they should use Vancozyn combination, or if you're in a patient situation where you're going back and forth between cefepime, meropenem, and Zosyn. I would much rather at this point use Vancomycin and Zosyn versus adding on meropenem at this point. So that's my big thing that I'm going to take away from this. Do you have any other final thoughts or comments that you want to mention on this topic? Vancozyn, AKI, and biomarkers, or just anything in general?
Yeah, well, so the one thing I would say is again, ours is a single study in a critically ill population, and so an important question is, in our population had a high baseline risk for acute kidney injury, and so an important question will be how and to what extent these results can be extrapolated to other populations, so non-critically ill patients, floor patients that have a lower baseline risk for acute kidney injury. So that's an important part of the next steps of establishing this. And I agree. I think the future is that we need to learn how, to develop algorithms to use these alternative biomarkers in a thoughtful and cost-effective way. Because particularly in the setting of nephrotoxicity, being able to differentiate changes in kidney function from actual kidney injury and damage to the tubules is, there's many drugs that, Vancomycin, ACE inhibitors, NSAIDs, right? A lot of the key things that we worry about with changes in creatinine, being able to differentiate, functional effects from actual toxic effects would be, very clinically useful. And I think that's going to be the future.
Perfect. Well, again, I definitely appreciate you coming on. This is, again, one of the papers that as soon as I saw it, it jumped out at me. So I congratulate you and your team from conducting this work, because anyone who's involved in research at any degree understands the challenge and the rigor of it. And for you to dedicate a significant portion of your career now to doing and understanding research and publishing high quality data is amazing, especially after the couple of years we've went through with COVID quality. And so we really appreciate a good paper when we see it. I thank all you guys for listening to this episode. And as always, you can check us out online at pharmsohard.com. We're available on all social media platforms. Just Google Pharm So Hard, Instagram, Twitter, LinkedIn, all those things. And of course, guys, if you like this information and you want to get something a little bit more hands-on, we have our academy at Pharmacy and Acute Care University. So you can go ahead and check that out. And I'll put that in the show notes as well. But again, thank you for coming on. And guys, we end it the same way we always do. You don't have to be a pharmacist. You're not working at ED, but everything you do, make sure you Pharm So Hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.